Everyone who joined today, thanks for joining in. Uh, I think I sent I basically sent out this presentation uh, after I was done with my thesis defense, which was last week on 19th March. Uh, the topic measuring access to surgical care in rural India, uh, synthesis of data and novel index. That's basically my thesis. That was my thesis topic uh, l- last year and this year. So uh, a lot of folks at ASAR like heavily contributed to this, and which means they also contributed to my thesis, and are also going to be authors on the papers that we are now drafting and editing coming out of this. So let's get started. Oh, before that, just quickly, the Gemini thing that you see here, that's my lab at Duke. It's called Global Emergency Medicine Innovation and Implementation Research Lab. And although it's emergency medicine, very weirdly, we are based in Department of Surgery for some reason. So yeah, that's why that, I mean that's why it's like I could do this as a topic in emergency medicine lab. Oops. Okay, cool. So a little bit of background. Until 2015, there was little movement towards surgery as a global health topic, and for a long time, surgery was thought of as a luxury treatment for high-income countries. Even in India, uh, even now, surgery is very heavily focused in um, urban centers, predominant in metropolitan cities. So in 2015, Lancet Commission on Global Surgery kind of had a very strong message to send. One was that something that saves lives on a daily basis cannot be considered a luxury. Uh, so their first message was that no universal health coverage is possible without including surgical care in it. Second, they also demonstrated through different methods that surgery is cost effective. And in fact, a lot of surgeries, such like essential surgeries, such as cataract, cesarean, are even more cost effective than a lot of vaccines. So I think that helped a lot to bring surgery to within global health, within public health realm, and then uh, also on health and public policy agenda. The last thing which they the last kind of big umbrella message which they had was that uh, it has a spillover effect on other dimensions of societal well-being. So for instance, they showed that including surgical care within your basic universal healthcare coverage insurance packages could actually help in pulling out people from poverty. Definitely, it helps in reducing societal level disease burden. So definitely, it has effect on morbidity, mortality. But I think at least for people beyond health, reduction in poverty is still a major agenda item. So that was helpful. One of the major results that came out of the research associated with the commission was that they estimated through a model that about 5 billion people lack timely access to safe and affordable surgical care, and a fifth of these 5 billion uh, live in South Asia. So, which and India is the largest country in South Asia. So, and we will come back to how they went about defining access, but they had two simple recommendations that to improve the access, especially for LMICs, first thing, get more data, monitor your data, synthesize more data. So there was that. And second was that we need to create national surgical plans based on what insights we have from these data. And then the idea of national surgical plans was that you can include pointers from these plans into the national health policies. Coming to access, the commission looked at kind of four dimensions: timeliness, surgical capacity, surgical safety, and affordability for getting surgical care. And then they defined access as a joint probability, which vaguely or loosely means product, but it's little bit more complicated than that. But a joint probability of these four dimensions, and based on that, they estimated how many people have access versus how many people do not have access. Uh, this model definitely has certain limitations. One being that it kind of looks at the access problem only in a binary way, where it's access versus no access. So there is that. Secondly, estimating joint probabilities for multidimensional data is mathematically a tricky problem to solve. Computationally, it's a heavy problem to solve. So one of the reasons why they had to make it like like had to make it categorical was because if they would have used continuous variables, where they would have given certain score for timeliness or certain score for capacity on, let's say, a scale of 0 to 100, uh, this problem just becomes less and less tractable computationally to solve. uh, Not to mention that getting inference out of that is even more difficult, as to, like, whatever the final number that you get, what exactly does it mean. So regardless, the model was definitely useful to put this idea of access into people's heads, and make sure that when people think about surgical care, it's along these four dimensions and not just about one particular thing or two particular things. Okay. With respect to India, in 2019, after coming here, we had like a global surgical care course that I like elective course that I took. As part of that course, I did a lot of literature review. I also got the opportunity to interview a lot of big people who are involved with surgical care globally and with India's surgical care more specifically. So, uh, one of those people was Dr. Rani Bang, who is also a member of National Surgical Forum, and as some of you may know, founder of Search. Uh, and while interviewing her, like the thing that kind of got me inspired to work on something like this was that she said ki after so in 2016, Lancet Commission along with few other partners in India conducted a national surgical forum, and in that forum they signed a consensus statement called Karat Consensus Statement, which is basically a laundry list of all the things that India needs to do to improve its surgical care. So after signing the Karat consensus statement, there has been a little bit movement in the last 5 6 years, but at least to her, it seemed as if nothing is happening in India uh, because of a lot of reasons. One of them being that there is little interest from the local stakeholders, and more importantly, there is little political will for surgical care right now in India, and we'll come to why that's the case. uh, in my literature review, one of the major studies that was done recently, which was a global comparison of surgical care indicators, uh, I came across basically the same thing, which said that data availability remains low for a lot of LMICs, and also including India, because out of kind of 5 6 variables that usually global surgical people look at, India had only one of them available out of six, and even that was available from 2009. So, okay, we basically have two big problems right now. Uh, Before we can start planning before we can start like a national surgical plan for Indians. One is at the research end. So the Lancet Commission generated country level estimates in 2015. After that, they created an initiative called Global Surgical Care Indicators Initiative. They have also attempted to integrate like these indicators into the world, uh, development indicator data set. And they have had two reports until now. One published in 2015, so just after the commission got out, and another one published in, like, updated one published in 2017. A 2019 one should come sometime soon, I'm guessing. But across these both reports, there's basically no new data on India. Uh, so more importantly, not just nationally, but even subnationally, we do not have subnational estimates for India with respect to a lot of surgical care variables. Most importantly, the access dimensions that we were talking about earlier. So that's at the research end. At the policy end, like I said, that the commission led the surgical forum, which generated some momentum. And there have been a few implementation activities kind of working in isolated fashion in last 3 4 years. uh, and usually the way they have went about, uh, for India, or rather India's surgical planning, is that they are following kind of a bottom up approach where they gather multiple stakeholders from different pockets and then try to pitch in ideas, which at some point high level policymakers and politicians may take up in the past. So in general, like, in general, implementation science has these two approaches, where one is the bottom up approach and second is the top down approach, where policymakers come up with certain agenda and then they get researchers involved, they get other local health planners involved, other district authorities and, like, district state authorities involved. And it's mostly like, let's collect the data, let's see how big the problem is, let's get money and let's get started on it. For a lot of LMICs and for India, uh, consistently we have seen that uh, the top-down approach works a lot better compared to bottom-up approach. A lot of reasons for that. One reason being the structure of governance that we have. That health, although it's an item on the concurrent list, so it's a state, like, it's a state agenda, like state item and a central government item. Even then, the contribution in terms of funding, contribution in terms of agenda setting, almost always comes from the central government. So that's a big reason. Second reason with respect to this topic is that usually policymakers like to work on topics which have data, which have been measured, where they know that where they know the magnitude of the problem. So they also know how much return on investment is. So how, like, if they have to spend money on including something on in the universal healthcare coverage package, they would like to spend money on something which is known to have high return on investment. So unless you have data on all of those things, no policymaker would be interested in working on something just for the sake of it. So we basically have these two interconnected problems where there is no data, so no policy interest. But since people are following the bottom up approach, so there is no policy interest, so there is no push for creating new data. And, like, the plan for my thesis and even, like, in general what we are doing within surgical care in ASAR. By the way, just to mention, like, what I did as part of my thesis, uh, and what we are doing in surgical care in ASAR, they are related, but they are not the same thing. So in ASAR, we are focusing more on uh, India as a whole. My thesis was focused more on rural India, and the way it worked out, whatever I did in my thesis, is now going to translate into more work for us, sir. Anyway, so we have these two problems, and the plan for the thesis was to tackle both of these in some way. Of course, like, being predominantly a research thesis, it's going to tackle the first problem of lack of data more. Okay, so this was mostly meant for kind of uh, international audience. So maybe all of you have an idea about it. But the reason wanted to focus on like, or at least I wanted to focus on rural regions in this thesis, was because large section of Indian population is still rural. Rural healthcare has been severely neglected for about 200 years now. Uh, mostly under the colonial rule, also under the Indian government until 2005. And like Shweta can talk about this for a long time, but that's also where the inspiration came from. That it's a neglected population which needs its own data. Uh, Rural places are also known to have higher disease burden compared to the urban counterparts, even after adjusting for all the confounders, which was one of the biggest results from the National Burden Estimate study. Uh, More recently, under NRHM, rural health is priority now, luckily. Also, the most important thing was that the Karat consensus statement that I mentioned earlier, it was drafted mostly by the Association of Rural Surgeons of India, and that statement focuses heavily on the need for new research with respect to rural population surgical care needs, uh, also need for new technology, need for new economics research for these people, and so on. Okay, so we- I kind of had four aims here. First was, and the first aim was broken down into two. So, first, synthesize data and assess geographical variations just at least visually for the surgical care access dimensions. So, if you have forgotten till now, those four things: timeliness, capacity, safety, and affordability. That's what the that's what kind of the thesis focused on. Uh, then the aim two was to create a composite index for measuring access, and this was the first aim is entirely within the research domain. The second aim is kind of at the interface of research and policy. In the past, uh, for everything from the Human Development Index, SDG Index, and all these, there are about 400 indices now that people use, multidimensional poverty index, that people and policymakers use. So a lot of times it has been observed that once you create an index, for some weird reason, policymakers start using that, and once they start talking about it, the issue comes to uh, like the public policy agenda, into public discourse, in the eye of politicians, and a lot of things get momentum just because they are measured as some multidimensional index, and inherently people always find it easy to understand that number, even if they don't know what goes into that number. It's still easy to convey it as one number. And then most importantly, it's easy to compare things across time and between places. So that was aim 2. Aim 3 was to assess spatial and distributional inequalities uh, in the axis as measured by the index. Last aim was to see how our index is associated with SDG for aspirational districts and states. So uh, 3, 4 were entirely policy, 1 was research, 2 was at the interface of research and policy. Okay. So data synthesis, aim 1, these are like the four dimensions. So for each dimension, you basically have a proxy variable as to how. So dimension is basically a concept, and then you need to create a variable that you think measures that concept well. So for each dimension, we had one primary proxy variable, and then also other kind of sensitivity proxy variables, where the idea was that from the research end of the problem, uh, most people are never interested in just one number, and for even for creating an index, for understanding access dimensions, you need to have a sensitivity analysis just to see how if you how robust your findings are under different assumptions. I guess that's the best way to put it. So for timeliness, we had proportion of population within 2 hours of their nearest surgical care facility, uh, with surgical care facility being considered as the one which is able to provide the basic procedures listed on the screen. Capacity was basically met surgical need with respect to the rate of major surgeries, and the threshold that we used for comparison was 5,000 surgeries per 100,000 people, which was also the threshold used in by the Lancet Commission. Uh, Safety was proxied by the rate of or the proportion of surgical site infections, and affordability was the proportion of households uh, with at least one surgical hospitalization case facing catastrophic health expenditure, with definition of catastrophic health expenditure given there. That's the most commonly used definition for CHE. It was also used in Lancet Commission. So proxies for timeliness, capacity, and affordability are exactly the ones which were used the in the original Lancet Commission research. Uh, Due to data availability limitations for safety, we used SSI. Lancet Commission had used uh, kind of safety scores for surgical care facilities. Okay, cool. So the biggest problem here, or kind of like the problem in which we spent a lot of time, was data assimilation. The common year that we chose, the unit of analysis that we chose was district. Common year was 2017-18. We did analysis for 36 states and union territories, uh, and then for 666 districts, which were referenced from the GADM, which is a global data set for administrative boundaries. And then across different data sets, of course, some districts didn't match because new districts are created across years. Uh, so we had to remove those districts from the analysis for now. Okay. So for the timeliness dimension, uh, one of the important component was the surgical care facilities, and we had to create our own geocoded database for that. So all these four databases went into its creation, uh, and then we used data from different sources, which went into calculation of proportion of people. So just quickly, the Malaria Atlas project map provided the motorized transport friction surface, which was used to measure the time to travel for these surgical care facilities. The urban rural catchment area raster. For those of you who don't know what a raster is, it's basically just raster is just an image, so it has pixels, uh, with the addition that these pixels have a reference coordinate system which matches the longitudes and latitudes. So we use the URCA data to get the categories of urban and rural areas in India. Uh, and then we use the world pop data set to get the population estimates at very high resolution, like 1 kilometer square resolution. And finally, the GADM to get kind of the state and district boundaries. So in general, the gray boxes show data set that directly went into estimation of the proxy variable for that dimension. White data sets are basically that indirectly contributed or were used for validation. For capacity, we use the health management and information system data, HMIS data, which is collected monthly at sub-district level. We kind of created district, state, and national level aggregates, uh, annual aggregates for these. For safety, also we took the data from HMIS. And then for affordability, we took data from National Sample Survey, 75th round, which looked at health consumption and lot of health expenditure data categorized by nature of treatment. So that's why we could get surgical care expenditure data from there. And then NSS is nationally representative survey with about 95% geographical coverage. For AIM4, we took data from Niti Aayog's SDG dashboards and reports, but I'll come to that later. Okay. So for creating our own geo database for surgical care facilities, we evaluated 9 databases, excluded 5. For the 4 that were included, there is a list of facilities that were considered as those providing surgical care facilities. Again, just to remind you of the definition, the facilities which were able to provide uh, C sections, then management of long bone fractures, and laparotomy were considered surgical care facilities. Okay, so within each of these four data sets, uh, the listed facilities are thought to have provided one or more of the uh, surgical care operations. Okay, we did manual and kind of like API based geocoding for these facilities, uh, then removed some of the erroneous geocodes which were kind of beyond the limits of uh, like the box that contains India. And finally, we had also removed the duplicates. And finally, we had 20,000 total surgical care facilities. In sensitivity analysis, we use facilities from NHP and NIN datasets. So, because these two datasets mostly contain public facilities and teaching hospitals that are considered to provide subsidized or free care. Cool. And this is how the data set looks once we plot it. So as you can see, mostly it's NIN and PMJ facilities. Uh, as it's pointed out in red, even after removing things kind of outside the box, there were still a few points which were definitely erroneous. But we don't think they affected our analysis because the density of like the ratio of these points to others is quite small. Okay. With respect to how, so one sad thing was India does not have district level population estimates for 2017-18, which means we had to create our own, and these were used for timeliness, capacity, and safety analysis. The way we created these population estimates was that we took the global URCA raster, cropped it to get just the India, then uh, so this raster basically had categories of catchment areas. We binarized it into two groups, rural and urban. Uh, and then we took the population raster from World Pop, multiplied these two rasters. So what that basically means is that within each of those pixels, the binarized raster had value 1 if it was a rural area, or value 0 if it was urban area. So when you multiply the population within each pixel with these numbers, you basically get the rural populations, because for urban populations it's multiplied with 0 everywhere. Okay, so that's how we got the rural population. And then we overlaid the state boundaries, district boundaries on it to get the district and state level population estimates. Uh, and kind of the similar procedure was also used for calculating the population which was within 2 hours of surgical care facility, but I'll come to that a little bit later. But it was basically the same kind of algorithm. Okay, so luckily we had state level population projections from the census for 2017, and we wanted to check if what we did, if it matches with the census projections, and looks like it does. So which means like the method that we are trying for estimating populations, uh, it kind of works well. Definitely it will need more validation for other data sets, other countries. uh, Even so, uh, we are right now creating a shiny application for the population estimation, which means that you can create, using that application you can create high resolution population partition of whatever kind you want. For instance, if you want females within the age 15 to 49 living in rural areas at 100-meter square resolution in Uganda for this particular region, you can use the application to get exactly that number. So, uh, that said, let's move on to, yeah,
Siddesh, before you start, we only have a minute left. So can we restart the session?
yeah, we can. And I'll go over things much faster when we restart, because I
Okay.
think we have spent a lot of time on the background.
Okay.
Cool. Okay. Like, does that mean I'm waiting here?
No, the session will end and you'll have to rejoin the session.
Cool. Cool. So again, like I said, it was basically the same algorithm for getting the count of people that were within 2 hours of surgical care facility. Uh, so what we did was we got that accessibility motorized travel friction surface from map, and in this each pixel is basically a value of inaccessibility weight. Okay, which takes into account the topography of a region, weather conditions, availability of road, uh, and I think more like 2019 raster also considers speed limits and to some extent the known traffic flows. Okay, and based on that it creates the weight. So we cropped it to Indian boundary. Then we added our geocoded facilities list and ran the famous Dijkstra algorithm, which basically calculates travel costs from each pixel to each of these facilities, and then tells you key then basically tells you how much time it takes for a given pixel to reach the nearest facility. Let me know if that doesn't make sense. Uh, but basically, the final thing that we get is कि 1 kilometer square के resolution पे we have each pixel as time in minutes required to reach the nearest surgical care facility for that pixel. Okay, so once we had that raster, again we binarized it based on our 2 hours wala threshold. So places within 2 hours or like 120 minutes were given one value, others were given zero value. Multiply it with population, and you basically get all the people uh, who are within 2 hours. And here, since we were interested in rural, we used our rural population car raster. Okay.
Siddesh,
Yeah.
can you hear me?
Yeah.
Okay. Uh, can you so for this MAP accessibility wala grid,
Yeah.
can you describe how the distribution looks like typically? Like,
Oh yeah. Yeah. I can. I can. I mean, I can. Yeah. Show you. So it's mostly skewed.
oh, interesting.
So for a lot of places, like yeah, I mean, globally it's mostly skewed. So like this is for India, but at a lot
Okay.
of places it's going to be like less time taken to travel, if that makes sense.
Yeah. Yeah. Oh,
Okay,
okay.
cool. So
Sounds.
and this is basically how it looks. That for time taken to reach nearest surgical care facility, this is our heat map, which shows, and then you can see it's mostly blue, which means it takes 0 to 30 minutes to reach the nearest facility for people living in each of these pixels. So like the resolution of this is basically each point is 1 kilometer square. Okay, so given India's area, that's about I guess 3000 data points, yeah, or more. Okay, anyway, so uh, as you can see it's mostly the north Fala region, northeastern regions, and then again like the Kutch, Thar desert, and then like a patch of red, yellow, green points in central India and like this. But at at a lot of places it's still blue, which means within 30 minutes you can reach the nearest surgical care facility, assuming that you have access to a motorized vehicle. Okay, and like Pushkar asked, like the distribution of like these points basically looks like this. Okay. Uh, then to look at geographical variations for the axis dimensions. So, by the way, like a lot of time was spent just on getting this first axis, like first dimension data, because it required creating, let's see, creating this, it required creating population, uh, then creating like the accessibility map. So a lot of time was spent for just one variable. Others were little bit simpler. But with respect to proportion, like percent people within 2 hours of surgical care facility, as we had kind of also seen in that previous map, about 99% of rural population is within 2 hours of their nearest surgical care facility, with some districts, with north and northeastern regions being the exceptions. Okay, with respect to surgical met need, and let's to remind you, surgical met need was defined as a ratio of surgical major surgical operations rate to 500 surgeries per 100,000 people. Again, major surgeries being one that requires spinal or general anesthesia. And we found that at national level, a little less than 50% people, like the met need is little less than 50%. As you can see, there is like a lot of districts in central India do not do well. They are within 0.25 with respect to met need ratio. Uttar Pradesh, Madhya Pradesh, Jharkhand, Chhattisgarh not doing great. Southern states doing much better. One weird thing I do want to point out quickly is look at this. Look at Arunachal Pradesh, and then look that the entire state is dark brown, which means low met need, with just two districts which are doing super well, where they have completely like where they are at like at 5,000 surgeries per 100,000 people ka threshold, or maybe even a little bit more. And then if these are high population density districts, they kind of drag the entire state upwards. So the color of the state, it looks like that is about like 50% to 75% of the need is met. uh, and it's due to things like these that high resolution analysis is required, because if like national policymakers or even state policymakers are looking at this map, it looks like okay, Arunachal Pradesh may not be like Arunachal Pradesh may not need our attention so much, we should focus on just these. But when you look at something like this, it's very clear that a lot of districts in Arunachal Pradesh actually need our attention, right? So
Hi,
that's
did
yeah.
you get to check the error estimates for this NSS
Well, these do
75?
not have error estimates because this is aggregate data, right? Like error
Uh,
estimates, like error propagation only comes into picture if you have sampled the data.
this is from NSS 75 only, right?
No, this is from HMIS.
Oh, okay, sorry.
Yeah. Uh, so yeah. Okay. Then going ahead, kind of same goes with Maharashtra. Like look at these blue, yellow regions, then entire Marathwada and this being red. Then again you have blue, blue. So again, not a great idea just to look at states. We need to look at districts. Even better, we need to look at sub districts. Okay. For surgical safety, which was proportion of post-operative surgical site infections relative to total surgeries being major plus minor. Uh, that proportion also was quite low. Most of the places are below 0.5%. Uh, Dark secret to be shared with all of you. I do not trust this data at all. This is definitely uh, badly entered data where people have not reported their surgical site infections and kind of maybe have even, I guess, tried to underplay it. So we are now creating a model to take care of that problem. Apart from that, we also have a lot of n like not available and zero values in this data set. So that's also a reason why like the entire data is being pulled down. So I don't trust it very much, and we are creating ways to mitigate that. Okay, with respect to surgical care expenditure, a booming 61% of surgery seeking rural households face catastrophic health expenditure at the 10% threshold, meaning that they spend out of pocket for surgical care, like their surgical care expenses out of pocket are above 10% of their annual household expenditure. Okay, so most of the India is in red, dark red. A lot of districts, as you can see, have over 50% people who are facing CHE. This data was from National Sample Survey, and like this is based on the average estimates. Pushkar has now created the error propagation as well. So for the paper, we'll also like have that, like maybe have like those maps showing the average, then lower 95% credible interval upper. So for this one, yeah, uh, maybe for small places the estimates might be a little bit uh, undersampled. Okay. The second aim was to create a composite index. We wanted certain properties that it needs to include appropriate indicators. Here, we are taking surgical care access dimensions which have been vetted well by the Lancet Commission. Next, it should be simple to compute and interpret. That's why we didn't want to use those complex analyses like PCA and data envelopment analysis and stuff like that to create the index. We wanted something very simple. Next is non-compensatory or partially compensatory. So here the idea is that if you are looking at, like if you're trying to combine multiple indicators or multiple dimensions into an index, uh, let's imagine the easiest way to do that is to create an average, right? Just the basic kind of arithmetic mean that we have been doing since second standard, that thing. A problem with that is there progress in one dimension can actually compensate for deterioration in another dimension, and the average would look the same, right? Uh, and then what usually happens is that your one attribute gets neglected, and only the attribute which is doing well, people focus more on that and just try to make sure we reach the 100% mark for this one thing that we are doing quite well. uh, and even then our total score will be great, right? So we don't want that to happen. The idea is to have a balance across dimensions. So we wanted to make the index non-compensatory or partially compensatory across dimensions. Next property is that it should be comparable across regions and periods, because only that's when policymakers get a little bit competitive and start using the index and uh, start working on the problem. uh, it should also be robust to outliers. uh, I'll cover this in the next slide. And then we went with no weights, or basically equal weights, and that's because that is considered to be the most non-controversial approach. Weighting is useful, but weighting also brings its own problems. So we named it. That's my surname and my professor's surname. Uh, and then the range of the index is 0 to 100. The polarity is positive, meaning that lesser the value, worse you are doing with respect to these surgical care access dimensions. And yes, it includes these four, like proxies for these four dimensions. So the primary index includes the primary proxy variables, and then we created a library of index values, which includes like the combinations of the sensitivity proxy variables. Okay, so any index creation involves basically three main steps: uh, normalization, weighting, aggregation. Since we didn't have weights here, our procedure is reduced to just two steps: normalization and aggregation. Normalization basically means that we want to bring each of those dimensions on a common scale, so that they can we can calculate a mean or like whatever we want to out of them, right? And then for normalization, people usually use minimum, like in denominator people usually use maximum minus minimum. uh, and that's problematic because if your minimum is zero, or yeah, mostly if your minimum is zero, uh, that kind of skews the data, uh, actually by a lot. So that's why we used the 97.5th and 2.5th percentiles, and that's what makes our values robust to outliers. Also, before aggregation, we kind of censored the values. So due to this, due to this way of normalization, there there were some values that were kind of negative, right? So we just like cut them at zero. So any negative value was taken as zero, any positive value greater than 100 was taken as 100. Okay, so using percentiles and censoring makes it robust to outliers. In aggregation, to make it non-compensatory, we added a penalty term. So this is standard deviation into coefficient of variation. So we calculate the arithmetic mean and then we subtract the product of standard deviation and coefficient of variation. So what this does is that since you're calculating like this mean, the standard deviation and CV across dimensions, if let's say there is a district which has quite variable scores for these different dimensions, the the aggregate index value of that district will go down because we are penalizing the variability across dimensions, right? So if the SD value across dimensions is high, the index value will go down. Does that make sense? Any thumbs up, any yeses? Okay, I
Uh, okay, can you please repeat the last part, as in the
yeah,
like
yeah,
the term that you have highlighted on the
yeah.
S
So so
analysis?
this is a product of standard deviation and coefficient of variation. Coefficient of variation is basically ratio of standard deviation to the mean of the normalized values. Okay,
Oh,
so
okay,
what this is basically it's capturing your variability across dimensions, right? So if that value is high, then the overall index value gets penalized to be low.
okay,
Okay, and like that's how we want to make sure that there is a balance across dimensions, right?
okay,
So for
okay.
instance, a district which has let's say like let's say a value of 80 for timeliness, a value of 80 for capacity, value of 80 for safety, and value of 80 for affordability. The
Mhm,
standard deviation is 0, the coefficient of variation is 0, and the mean is
mhm,
80, right?
hmm, hmm,
For a district which has a value of 100 for timeliness, value of 50 for need, 20 for safety, and 100 for affordability.
hmm.
The SD value and the CV values will be actually high for that, and then the product will kind of like penalize the index score, like the overall index for that district. Does that make sense?
Okay, okay, got
Okay,
it.
cool. So again, we do the same censoring wala approach, and the final values are between 0 and 100. Cool. So this is how it looks after dropping the districts ki jahan pe we didn't have available data for all the dimensions. The final analysis included 587 districts. For states, we did it for all like states and union territories. This is how it looks. So for most of the places, uh, at state level, it's between 0 to 20, and for districts, it's between kind of 0 to 40. So most places are 0 to 20, others are 20 to 40. The best performing was Bhopal in Madhya Pradesh, worst was uh, Andaman Nicobar, North and Middle Andaman. With respect to states, best was Delhi, worst was again Andaman and Nicobar. Uh, if you're wondering ki, why does this score look 0 to 20 and then maybe here it was all blue, here it was all green. So again, just to show you ki this is still red and dark brown for a lot of places, and in fact below 75 for most of the places, and this is booming red for all the places. So when you put all four of them together, it's basically that capacity and affordability are taking down the good, like kind of the goodness of timeliness and safety. Okay, again, since these are scaled, like like you should not compare the districts with the states. Okay, so you cannot compare ki acha ki like they say okay, so Nagpur is doing like this and Maharashtra is doing like this. So those scores are not comparable. Like the comparison is possible at a given geographic resolution. Cool. Assessing the spatial and distributional properties. I'm not going to go into methods of these too much, but we just like what we did was basically identify clusters of districts ki jahan pe like a district with high value of the index is surrounded by districts with other high values. So like that basically comes in this quadrant. Then here it's basically district with low Zwaski values surrounded by other districts with high Zwaski values. Then you have low clusters, and then you have high low outliers. Okay, so and this is basically called a spatial autocorrelation. Ki across space, how is the value of the index varying? Uh, but 0.22 is not a high value of spatial autocorrelation. Then we kind of also mark these districts based on their significance as to, so these are basically high, low, and then some of these are low, high, and high, low outliers. Again, I don't want to go too much into this right now. We can definitely discuss after we are done with all the findings. Okay. With respect to distributional inequalities, in economics, inequality is kind of a big idea, and distributional inequality means ki if you have, let's say, the unit of analysis is district, and the groups that we considered were states. So uh, perfectly equal distribution would be that each district in the state has the same index value, right? Perfectly unequal would be ki one state has 100 and all other states have zero values. Okay, so we use the Thale index and the extended Gini index to measure the distributional inequalities, and we found that within state inequality was kind of about 2.5 times the between state inequality. And this is significant for policy making because that means we need to involve state health officials and state policymakers who can act on reducing these within state inequalities, right? Okay. Last thing was to look at relationship between R index and the SDG index. Quickly, just a refresher ki what are aspirational districts. This was an initiative created by government. Niti Aayog is leading it. They are calculating indicators for these places. And these are kind of the bottom performing districts, 101 districts, which need very immediate developmental push. The idea is to bring them up to the states, like respective states' best district by 2022. Okay. So we didn't find a significant correlation between uh, our like surgical care index and the SDG composite score. Uh, a couple of reasons for that. If you look at this, for a lot of these districts, we just have like a flooring zero value with respect to our index, even when they have like variable values with respect to SDG composite score. So there is that. Second reason is that all of these districts are kind of bottom performing districts, right? So uh, maybe they are just barely able to manage their healthcare, and that's why when it comes to surgical care, like that's not even a thing that they are focusing on right now. But we kind of found a similar lack of relationship between our index and the SDG composite score for the states. Again, the same thing, that we have a lot of zero values, and this pointed us to the idea that we maybe need to adjust our scaling approach a little bit, and that's what I'm working on right now. So now I'm working on a way where we scale it in a way that it's robust to outliers, but then I don't have to censor the values, so something like this does not happen. Okay, but it's so even like even if we neglect this scaling wala like limitation, even then it's not a surprising result. So similar result has been observed at a lot of other places where when you look at surgical care, it does not typically match with other socioeconomic developmental indicators, uh, and that just means that surgical care as an agenda needs to be added to policy making, And you cannot assume that just working on, let's say, human resources for health or vaccination and blah 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 will automatically take care of these other aspects of health system. Okay, so these are our insights for policymakers. But the biggest insight is ki basically we have a situational analysis ready now, which can be used for national surgical plan. All the analysis that we did for rural kind of also did for urban, except the creation of index because safety data was missing for urban places. Okay. Uh, in terms of research, all of this analysis is open source. We are creating shiny applications for a lot of these pipelines so that they can just be used as drag and drop tools. And then we think that the index can, like, not just within India, but index can be actually used for global comparisons. And we are working with the Harvard group to to propose that now. Okay. The kind of the most exciting things were that this was kind of the first ever high resolution subnational estimate study for India. We did separate rural urban analysis. We created a geocoding database for surgical care facilities, introduced an index, blah 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 blah. And as we had covered earlier, we still have errors and a long list of to dos for our geo database. Uh, we need to we like I don't have a way to do this right now, but basically we need to have a way to visualize the data for districts that are not included in GADM. So these are about like 30, 30 or even maybe 50 districts. So we need to make sure that those are included. Like I said, the SSI data had a big zero inflation problem, and we are correcting that right now. Uncertainty propagation was not included as part of this, but Pushkar has it now. Poverty lines were not adjusted for inflation for the empowering health expenditure calculations, which I didn't show actually. So anyway, uh, but even like this we have removed. So Pushkar and I are working on this as well. And then the next step is definitely to do like a good validity reliability analysis for the index, which wasn't part of the current study since that's its own study. But yep. So that's my professor who was also my thesis advisor. These are my thesis committee members. All the three people are kind of have like hired me for the next year, so I'll be working with them for another year. Uh, and then this is a postdoc from our lab who helped me a little bit with uh, like geocoding and accessibility stuff. And then these are all of you people who helped with all different things. Shweta helped me with a lot of thinking over stuff, and in the last steps with geocoding. Pushkar has been a very essential component of this like entire surgical care project, from putting together the HMIS data set, putting together the NSS data set, doing a lot of sample level calculations for the NSS data set. uh, Swati helped Pushkar with the HMIS data set ka data. What would you call it, Pushkar?
Consolidation, maybe.
Yeah, consolidation. Yeah. Then Himanshu and Tanmay helped us with a lot of geocoding, getting the CGHS data set in place. Rachit did the first ever geocoding that ASAR as a group did for teaching hospitals, and just did a lot of API based geocoding for PMJ and also CGHS. So thanks to all of you, and I think I'm done. This was quite long. Huh. I can't imagine. I completed this within 35 minutes when I was doing the thesis presentation.
There was a lot of background explanation that you have had to do this time around.
I guess, yeah. I guess.
So I have one question about the like in your equation, one of the variables, like you said, is the
Yeah.
safety
Yeah.
thing, right? And you said that the data is absolutely
Well,
incorrect.
yeah. I mean, largely incorrect, I would say, but yeah.
Yeah, I mean, it
Yeah,
looks
yeah,
too good to
exactly.
be
Yeah,
true.
yeah.
And from like my
Yep.
experience, I know for a fact that it cannot be
Like Duke
this
has
good.
an SSI rate of huh, about 12 to 16%. So 0.22% is
Yeah.
like definitely not correct.
And from what I know, from what I've seen in most of, like at least teaching hospitals, at least 70% of the surgical patients get infected. At least 70.
Yep, I would imagine it to be above 50.
So,
Yeah,
so isn't this kind of a
it is.
bias?
So which is why like I also have like sensitivity analysis. May I also have index values which just have three dimensions and not this one. So if we are not able to
Okay.
correct this data, we will either replace it with another proxy variable which probably has a good
Mm-hmm.
like good underlying data. Uh, so like one thing that we are looking at right now is like not that specific to surgical care, but still which is reflective of how the place is doing, which is like the inpatient death ratio. So number of inpatient deaths divided by total people that were admitted inpatient. And then that definitely includes
Okay.
like not just surgical care but also other like other specialties and departments. But even then that would be like, I mean, I guess that's like the data is definitely more reliable than something like SSI. We are also working on correcting SSI,
Yeah.
but I don't know, like the problem is ki,
It's
so okay, let me,
yeah, it's shared. I mean, I don't think procuring the original data will be possible.
well,
I
I mean
mean,
this is the
people
original data,
won't
right?
share the
So
real numbers.
like this is the original
No,
HMIS
no, no,
data.
like the actual.
So
Yeah, but
like we will have to
I
conduct like
mean, because
validation studies at certain district hospitals and blah
mm,
blah blah to like compare ki how were the values posted like kind of yeah filled in HMIS, how do they compare with like actual values that you get. But basically
okay,
we know that there is a relationship between surgical like volume and infections. So then in model we are kind of trying to, and then this is as you can see this is just for 304 districts. So basically after removing all the districts which had any values, which had even zero values,
yeah,
we know that for remaining districts this is what the relationship looks like. So we are thinking if like if like exploiting this relationship if we can correct the SSI rates. Okay,
okay,
instead of zeros, like whatever like you can see right ki this line if we you extend it beyond
mm-hmm.
even at
Yeah,
even like at like whatever value of procedures there is like a base minimum SSI rate, right?
yeah,
So yeah, I mean again like this is just a simple linear thing. Like actual relationship, if yeah if you can see it's not even that, like it's actually quite exponential, but this is already log log. So exponential within log log doesn't make sense. So well, model kind of is more flexible, so it can take care of non-linearity. But yeah, so yeah, we are kind of trying on two fronts, ki looking for another variable that could be useful or also correcting this variable.
okay.
Uh, Hi. You mentioned about the spatial autocorrelation part there.
Yeah,
So, I mean, let's not go into the methods, but can you tell me what does it signify?
yeah,
As
yeah,
in terms of, as in what? Why did you do that? In
yeah. So the reason people usually look at spatial autocorrelation is because uh, like for a lot of things there is usually a spillover effect across administrative boundaries, right? So administrative
Mhm.
boundaries are more from like logistic perspective,
Mhm.
but at a lot of times there is a spillover effect, especially as you go more high resolution, right? So if you go to more like sub district level and like then taluka level and zone level, there is
Mhm.
going to be
Mhm.
more and more spillover effect, like uh,
Mhm.
for instance zip codes. So like people living in my zip code versus people living in the next zip code are basically the same people. Like if you look at their economic status, if you look
Yeah.
at their professions, if you look at their other things, it's going to be the same,
Mhm.
right?
Mhm.
Okay, so that's the idea. uh, and that's why people look at and then like if you try to look at properties, of these people, so if we look at, let's say, educational background and income,
Mhm.
so apart from the correlation between educational background and income, there is also an underlying spatial variable that is acting for that correlation, right?
Yeah.
So like we are usually interested in that. And again, the final point is we want to identify places that could be focused on. So for instance, ki, like these are the places where, like, a district with high index value is surrounded by other districts with high index value.
Okay.
Okay, so the more and more such clusters you get, the stronger the case becomes ki, let's just push one district and there will be spillover for other districts around it as well, right?
Okay.
Right. uh,
Okay. Yeah.
so
Yeah. Getting.
identifying like such clusters, so like these are basically clusters ki low, then low are basically places कि जहाँ पे like the state health officials need to think about these places, right? कि this is like an entire chunk of districts कि where everyone is doing poorly, right? And then you have low high, high low outliers. So uh, like high low outliers are interesting because then basically like these high value isolated districts can act as, inspiration or champion for other places. Okay, we can see ki, like what is it that they are doing right.
Right.
So if you have like a high outlier in otherwise low area, जैसे यहाँ पे maybe,
The Arunachal Pradesh one maybe.
हाँ, so then like probably there is something to learn for other like nearby places, right? So but that's the basic idea.
Okay. Okay. Thanks.
So we have another 2 minutes to go. If anyone has any questions, you can please ask.
Um, Sudesh, can
Yeah.
you go to the like the variation, the mathematical wala slide,
Huh.
equation wala slide?
Yeah.
Yeah. In this, when you explained like the index or calculation about the standard deviation, you said that we calculated the variability or aspect of it,
Yeah.
and you said that as the variability increased, your index lowered. While calculating this, did you notice that when it came to the safety aspect and the timeliness aspect variability, like some districts had higher, some districts
Yeah.
had lower,
Yeah.
did it help in bringing down the index for that district? Did you notice that? Did that happen?
Yeah. I mean, definitely I did. Uh, well, so I mean, the district diagram is a little bit difficult to navigate because it's 600 or like 578 districts. But for states, I can show you. As mean kind of reduces, this variability kind of goes up, right? So so this is basically called a scissor diagram.
Oh, Siddesh, can we restart because the call will end in like 10
I
seconds.
am okay if people are okay with joining.
So whoever has questions can join again. Only one person, so we can do the questions. Everyone else can take a leave.
Yeah.
Is that okay, Siddesh?